Good evening, everybody. Welcome to the South Dakota EMS 2020 conference. Guess what? We're virtual. But hey, we're going to have a good evening. You know, yesterday we had some bumps when we were starting off, a little on the rocky side, but we've got most of those figured out. And I'm expecting this evening and the rest of the weekend to go just fabulous. So a couple of things to remember. In the guidebook for each session, there is a survey. Please take the survey. As I mentioned to some other folks earlier, that when we used to go to conference in person, long time ago, we got stamps in our booklet to show that you attended the session. Last several years, we have been scanning your name badge, again, to show that you were present during the session. Well, since we're virtual, you get to do the survey with the class that we're presenting. So make sure you do the survey so that we can give you the credit for the hours that you're attending. The hours between what we're doing live this weekend and then 6 hours that are recorded and will be available later on, you'll get your full 20 hours to meet the South Dakota EMT research hours and your national EMT research hours. All of these hours are also qualifying as ALS. So if you are a South Dakota Intermediate, an Advanced EMT, or Paramedic, these hours also count towards that. So keep that in mind that you're getting a good solid 20 hours of training just this weekend and watching those videos. Now we've got almost 500 of you registered, almost. So we're expecting a couple of more folks to hopefully join us over the next couple of days. But for folks who didn't register for the weekend, they can still register and watch all of the training afterwards. They need to register by December 15th so that they can get the hours and they can watch all the videos up until December 31st. At that point, we're going to take the training down so you can get your full 20 hours, whether you're registered now. So tell your friends, tell the folks that say, can't do it this weekend, I'm not going to register. Oh, have them register. They can still go those 20 hours for all the research hours. So have them join us. Let's see, I've got a checklist, so I need to make sure I verify that. You can register. Let's see. Just want to make sure that this evening we've got 2 live sessions and then we've got a vendor break. Please go into your guidebook and you can click and go to the different vendors. Some of the vendors have some really good offers to tell you about. Visit with them. It's a lot of the vendors who are helping sponsor some of the costs to offset doing this. So we do want to go in, see what they have, because some of them have some pretty cool stuff to tell you about. So please do visit them. So with that, for those of you who are brand new to EMS, and this is your first conference, because I think we have quite a few of you out there, I do want to say welcome to you. It's a strange way to start conference for us, but we're very happy that you're joining us. So we'll start off with you as new EMTs and the rest of us who have done EMS for a little while, having a lecture on something that we all hope we may not have in our career, but can come along. It is a low frequency, high risk type of call, which is pediatric cardiac events. Our speaker for this evening is Dr. Bill Waltz, and he will go ahead and take over. This is a live presentation, so this one we don't have for you to go watch at this time. But this is a live presentation from Dr. Waltz, so I'll stop sharing my camera and we'll get Dr. Waltz up.
And we are here. I think. There we go.
Hi, Dr. Walls.
Hi.
We'll have you go ahead and share your screen. So down
Yeah,
at the bottom, you should be able to share your screen to bring up your PowerPoint.
thought it was. I love the technology.
I see your calendar.
Okay.
I now see your calendar. I see your,
You
the
guys
little-
aren't seeing my face at all?
I see your, yes,
Well,
we do see your face over in the side, and we can see your link to the email for the Zoom.
Okay.
So if you open up your PowerPoint.
Yeah. Well, sorry about seeing my face. That's as good as it gets.
Oh, it's just fine. We appreciate you coming on with us. Okay, we see the PowerPoint starting to open. There we go. And we can minimize and move down. Excellent.
We'll make the rest of this go away. Well, while we're working out these technical issues, on a personal note, I really want to say thanks to all the EMS folks. I was actually an EMT back in the 80s. And then from there went through med school and all that, and pediatrics and peds cardiology, and did some quality time with the Air Force. And
Dr. Walls,
yes,
there's a white box that's showing on top of your PowerPoint. Can you just drag that off to the side or minimize it?
That's what I'm trying to do. It's be an ornery. Let's
Oh,
try this.
one of those days, huh? There, it's
See,
gone.
there
We
we
are
go.
set to go.
Okay,
Thank
sweet.
you.
I love technology when it works. Anyway, as somebody who is on the receiving end of whatever you guys bring to us, I really seriously want to say thanks. It makes a huge difference what is done in the field. We're going to talk today about something that's really scary and often heartbreaking, but is often actually filled with hope. And so I want to try to build upon all that and go through how we can give it more hope. We're going to talk about sudden cardiac arrest. Basically, we're going to talk about pediatric chest pain, which is a common thing, and when it is of concern. We'll also talk about pediatric syncope or passing out, and when we need to worry about that. And then we're going to talk about specific conditions which increase that risk. And these are some actual good basic questions you can ask people when somebody goes down to try to figure out what needs to be done and what sense of urgency you should have. So first, we're going to talk about chest pain, talk about the common causes, talk about non-cardiac chest pain in kids, and then talk about when chest pain is a real concern for the heart. So let's actually start off with the case, and this is real world stuff. A 12-year-old boy complains of chest pain. He feels a sharp pain like a pin in the left sternal border. It's worse when he takes a deep breath. It really only occurs at rest. It happens almost daily. He gets real anxious about it, but has no other symptoms, and it's been going on for months. And on exam, everything is normal from heart standpoint, lung standpoint, everything else. The only thing you get is that he is tender at that spot. He otherwise looks fine. And what this is musculoskeletal chest pain. When you look at the cardiac anatomy, it's an incredible creation. It's very complex. Besides the ribs and the sternum, there are so many different layers of muscle and soft tissue. You can imagine how many places there are to get little soft tissue injuries in there. And sometimes they never know why it happens. Sometimes it's throwing a football or starting martial arts or whatever it is, or just a cough. But it can really hurt. And the patients and then the parents get really worried about it. But this happens to a kid who is otherwise perfectly healthy and really has no other symptoms. The risk of danger in this is zero. But getting that kind of a classy history is very reassuring. When you break this down, you can see from the numbers a wide range of idiopathic, which means we're idiots, we don't know what causes it, for pediatric chest pain. Realistically, about almost all of the chest pain in kids is chest wall pain. You can get psychogenic. We're going to avoid discussing that too much in detail right now. Respiratory is common. Most of that is going to be asthma. Some of it's going to be pneumonias. The kids can actually get gastrointestinal chest pain primarily from reflux. The cardiac chest pain at a max, the frequency is 6%. Other studies show it's actually less than 1%. But just to make things more confusing, you can get organic or real causes and functional causes, which are something that the kids are just dealing with in their minds. They can both coexist. Classic thing, again, musculoskeletal chest pain is worse at rest. It can be worse with movement, even moving their arm. With exercise occasionally. Deep inspiration can make it worse as it's stretching that soft tissue, or by touching it or palpation, you can make it worse. Usually it's at the left sternal border, but it can kind of migrate all over the place. And that migration of the chest pain is actually very reassuring. They typically will describe it as sharp, like being poked with a pin or a pencil, something like that, but really no other associated symptoms. If you are dealing with a child with chest pain, it sounds musculoskeletal, but he has something else, like severe shortness of breath, passing out, palpitations, those kind of things, then I would take that much more seriously and get them in and get them evaluated. The non-cardiac causes of chest pain, again, asthma, really common. And actually, as a pediatric cardiologist, I diagnose a lot of kids with asthma and then send them on appropriately. Occasionally, we get the kids who actually are developing a pneumonia, and we deal with that, sometimes in infusion even. Spontaneous pneumothorax tends to be a sudden onset chest pain. It can be severe, really associated with significant shortness of breath, and it just doesn't go away. Those kids definitely need to get seen, because many of them need intervention to deal with that. Again, reflux can be a common cause, even gastritis. Once in a while, we'll actually get a child with such bad gastritis that they actually are bleeding. And those kids have severe pain, and they definitely need to be seen. Now, trauma can be a common cause for non-cardiac chest pain. I actually got referred a child for chest pain, and the pain was on the right side of his chest, actually way on the side where he took a baseball hit the other day. Okay, that's not the heart. But the 3-year-old with chest pain who was walking out around the horses unattended, and a horse kicked him square in the chest and put him through the barn wall, that's a different issue. That child had cardiac contusion, had all kinds of ectopy, and actually tore his tricuspid valve, and he had a pericardial effusion. So the mechanism of the trauma is very important. When we talk about real cardiac causes of chest pain, we're dealing with myocarditis or cardiomyopathy. It's associated with, often with GI respiratory symptoms, usually viral, can be associated with fever, have a recent history of fever or just mild symptoms, but these kids look sick. They're not running around and healthy. They appear ill, they're often tachycardic, feel really weak. This can be associated with pericarditis, which is an inflammation of the sac around the heart. And these kids, a distinctive feature of the history is that they lean forward and it feels better, and they lay back, it feels worse. You may hear a friction rub. It's tough to do over the system, but it basically sounds like rubbing sandpaper on wood, kind of a sound. They may have distended neck veins, their liver may be down, spleen may be down. They may have an elevated pulsus paradoxus. And if you get an EKG or even a monitor tracing, they can have low voltages and diffuse ST changes. It kind of looks like they're having a heart attack. Other causes of cardiac chest pain can be arrhythmias. Even though the arrhythmias by themselves usually don't cause chest pain, the kids often, because they're not that verbal, will describe it as chest pain. I think they mainly just think it just feels weird. On just a pivotal take-home note, the chest pain with exercise should always be evaluated before the kids continue activity, especially sports. When we're dealing with this, that's something to really be sorted out by a peds cardiologist to see if it's an issue or not. Especially if this all seems to be increasing, they need to be seen soon. Another keynote, you really need to react quickly if the pediatric patient, even again, pediatric, not necessarily adult, has known or suspected Marfan syndrome, because they can get real tearing or chest pain or back pain as their aorta tears. And we'll go into that in a little bit more detail. So if a kid ever has chest pain and passes out or really gets close to passing out, that's a concern. If they get a lot of dizziness with the chest pain, that's a concern. Significant shortness of breath, again, serious concern. If a child ever acts like they're just terrified of the pain, kids tend to blow stuff off pretty well and just say, get back into playing. But if a kid acts like he's just going to die, he definitely needs to get in, get seen quickly. And there are some conditions we'll go through where kids can have anginal chest pain, true ischemia. And in that case, the chest pain pattern they describe is very similar to that in adults. This crushing substernal chest pain, may have pain in the left arm up into the neck. So take that seriously. And as you're getting a basic medical history, ask about any heart problems at all. And hopefully the parents remember if they have a history of Kawasaki's disease, which is an inflammation of the coronary arteries. Those kids with chest pain definitely need to be evaluated quickly because they can have aneurysms, they can have stenoses and get true ischemia and actually die from Kawasaki's disease down the road, even years later. All right, next topic, syncope. Sometimes it's associated with a lot of drama, so it's kind of up to us to sort out what's real and what's not. So we'll go through that. We'll talk about the most common cause of pediatric syncope and talk about what non-cardiac pediatric syncope really is, and then discuss the syncope in kids that is a real cardiac concern. All right, second case. This is classic. 15-year-old girl with syncope. She's a healthy athlete. She had a basketball game last night. Actually went out and had fun with her friends, and they were goofing around. And she got up the next morning, felt lightheaded getting out of bed. It seemed to recover, but then she went into the shower, got really dizzy, vision went dark, she got nausea, and she woke up on the floor of the shower. Her parents heard the noise. She was out for probably a couple minutes, and she felt kind of dizzy afterward, but it really resolved in about 5 minutes. And when you get there on exam, she's lean but athletic, she's oriented, very normal exam, normal heart, normal lungs, well perfused. And this is a classic case of vasomotor syncope, and we see a lot of that. Actually, the classic case is a tall, skinny 15-year-old girl. Boys can do it too, and we'll see it at ages well beyond that, and younger than that, even 5 or less. But classic is 15. Syncope, really, the definition of it is a temporary loss of consciousness due to a lack of cerebral perfusion. And by far, in the pediatric population, the most frequent cause is vasovagal. There are a number of different names for it: vasodepressor syncope, vasomotor syncope, neurocardiogenic syncope. Some people like to refer to it as POTS, postural orthostatic tachycardic syndrome. But there's a real spectrum to it, but it's all really the same thing. And the reason for that, control of blood pressure is a remarkably complicated thing. And in kids, though, the systems just haven't matured as well as they have in adults. So what happens, basically, they stand up and they get a decrease in venous return, and then their blood pressure drops. And the baroreceptors pick that up, send information back to the brain, and the brain tells the heart and the blood vessels to get to work, increasing catecholamines in the system, increasing sympathetic nervous stimulation, so the heart just gets to banging away. But then there are mechanoreceptors in the heart that are picking up on that strong impulse, and they send an impulse back to the brain, says, hey, we're beating too hard. And so the brain sends out stuff to the vagus which increases the vagal activity and decreases sympathetic activity. And what that does is decreases the heart rate, contractility, and all that. So what we've got is these multiple feedback loops here that are just confused. And what happens is the blood pressure ends up dropping to the point where the kids lose consciousness, and then they go flat, and then the system reboots and they get up and they feel fine. Very common. The big solution for this is water and making sure you stay adequately hydrated. And it's something that they will typically outgrow. So again, the main causes, abnormalities of blood pressure control, benign as long as you don't hurt yourself, but very common. Cardiac abnormalities as the cause for syncope are uncommon, but they happen and we do see them. Seizures can happen. They tend to be classic with tonic-clonic movements, but not always. You can have different causes of that, so it's worth getting checked out. You do occasionally get the psychiatric conditions and again, those get really complicated, but that's left up to really a physician to sort out. Drugs can happen, certainly with drugs of abuse, can cause syncope through arrhythmias, and metabolic abnormalities, which are rare but definitely happen. We have kids that I can think of off the top of my head that I don't even follow, but the nephrologists do, and the endocrinologists do, that have metabolic abnormalities that can cause syncope. And if somebody has any of these underlying conditions, seizure disorders, known psych issues, known drug abuser, known metabolic abnormalities, then I would take that syncope seriously. Your typical vasomotor syncope or vasovagal syncope, again, is your teenagers. Girls do it more than boys, but boys can definitely do it. Some girls have trouble around the time of their menstrual cycle and then may actually respond to oral contraceptives to stabilize that out. Usually there's some precipitating factor. They get dry, often from sports. Sometimes it's because they're ill. Sometimes it's just in the shower. The kids who are poorly physically conditioned tend to have more trouble with it. And like in the case example, it's more common in the morning. Fasting is associated with a problem. It's rarely low blood sugar, but eating helps the body hang on to water, which really helps prevent syncope. Prolonged standing, it can be a problem, or position changes to the more upright. The classic one we see a lot is where somebody's laying on the couch watching something boring like House Hunters, and they get up to the kitchen to get something to eat and start feeling dizzy on the way to the kitchen and pass out. You can have trouble in choir and band at church with prolonged standing. Actually, Catholics have more of a problem than anybody else because of all the kneeling and standing that they do. But it can occur even while sitting in a chair in some kids. Some things can be triggers for it, like fright or anger, stress, sight of blood. One of my adult patients, who's way bigger than I am, has been through a couple of heart surgeries, big tough guy, farmer. But if he sees a needle, he passes out. So we deal with that. Sometimes smells can do it, or injury. Even a cough sometimes can stimulate that vagal effect. Sometimes voiding and hair grooming, believe it or not. Kind of the classic one is a 5-year-old girl with long hair getting her hair brushed before church with her mom, and she gets upset and passes out. When they get this classic vasovagal syncope, they get disoriented, kind of feeling of warmth, dizziness, nausea. You get those visual field changes where things get narrower, blurry, spots or dark. That's the kind of thing they'll describe. Actually, recently a little boy described it said his vision looked pixely. I guess that says where we are with our technology. Sometimes we'll get a loss of hearing or a rushing noise. Just kind of feel weak. They may look pale or sweaty, and then they go to ground. Sometimes they'll get some tonic-clonic twitching, but not usually. But there should be no incontinence. They should not lose bowel or bladder control. If they do, you really have to think about seizures. And in contrast to seizures, when they wake up, they may be a little bit groggy, but they're not really disoriented, confused. It should resolve quickly. They might feel tired, but they don't have that real classic post-ictal period. For the non-cardiac syncope of concern, you can get respiratory. Kids with asthma, pneumonia, pneumos can definitely do that and pass out from that. The metabolic problems like hypoglycemia, the electrolyte problems, even severe anemia can do it. Adrenal insufficiency, where you drop your cortisol levels, hypovolemia from illness can definitely be a precipitant on non-cardiac syncope. Again, seizures, hyperventilation, where somebody can be perfectly healthy, but you can breathe hard and fast enough to blow off enough CO2, raise your pH, and pass out. Little kids can have breath holding spells, and we can even see that in a year or so of age, up to usually about 5, where some of these kids are usually drama queens of either gender and will get really upset, hold their breath, bear down, and really increase their vagal output and pass out. Most of these are benign. We usually don't have to do anything to it except let them get older, but that can happen. Atypical migraines can be a cause of it. And again, you can get emotional or psychiatric issues, especially in the adolescent years, that can be associated with syncope. Yeah, but if you do have syncope, especially if things aren't quite making sense, definitely try to see if there's a history of drug abuse, whether it's the barbiturates, tricyclics, which a lot of kids are on for antidepressant, coke, meth. Meth is a big player right now, and you really have to think about that and play your suspicions and get these kids evaluated if you think that's going on. So when is it really concerning? When they have palpitations, when they can really feel their heart beating fast or abnormally, and then they pass out, that's a worry. If it's happening a lot, that's a worry. There may be something really organic going on. A big rule of thumb that I really try to drill into our students and residents and fellows is that exercise-induced syncope, they need to, 1, stop exercise, 2, see me without further delay, because they could be at risk of sudden cardiac death. Family history of recurrent syncope or sudden cardiac death would really raise your suspicions that this kid could die associated with a syncope, and you need to take it seriously, get them seen. If somebody has a known outflow tract obstruction, like somebody with hypertrophic cardiomyopathy, that is a huge worry with syncope. And myocarditis, dilated cardiomyopathy, and a bunch of other things we'll talk about a little bit later. Any kind of cardiac dysfunction and syncope definitely needs to be get them seen in the hospital, and get them to us. Somebody with known coronary ischemia, again, really rare in kids. But if they have it as a known issue, then that needs to be taken very seriously. Or if they have a history of cardiac arrhythmias, so ask them flat out, any heart problems, any heart rhythm problems at all? And if they do, then they need to get in and get seen. Actually, a subtle but huge red flag is if somebody has syncope with no prodrome. They don't remember any of that stuff we just talked about, the dizziness, the nausea, the vision changes, the hearing changes. They remember nothing but woke up on the floor. That is very worrisome for both seizures, but also for cardiac arrhythmias that could just drop you from your cardiac output falling. If they ever have injury from syncope, which happens, I mean, I've seen skull fractures, concussions, busted teeth, busted nose, arm fractures, just from passing out in a perfectly healthy kid. If that kind of thing is happening, then we need to see them, because they're hurting themselves. Okay, so we're going to now talk about something that's just scary. The term sudden cardiac death, I like to get away from that if we can, and really just talk about sudden cardiac arrest. We'll talk about that why. But these are conditions that put the kids at risk of sudden cardiac death. We'll talk about how they present and what we can do for interventions when it does happen, or even before. And there's a long list of things, but these people are your neighbors. A lot of these things are actually a lot more common than anyone wants to think about. And so when you're driving through a town, you're getting on a call to go somewhere, don't be surprised if you get one of these kids having a significant cardiac issue that's out there. This is a map of our region, and nobody should have the impression that all this is clustered around Sioux Falls. I mean, it's the most dense area, but all these stars are where we do outreach clinics in peds cardiology for our program. And the reason we do that, it's not just for convenience of the families, but we're really trying to reach out and get these folks that are having cardiac concerns and get them seen. And we see at every one of these places, kids that are at significant risk of sudden death. So it is definitely something all over the area. The classic way of dealing with sudden cardiac death was to put somebody over a barrel, roll them back and forth. I'm not sure what the axe is for. I'll leave that up to your imagination, but not very effective. We're getting a whole lot better at resuscitating, especially when you folks in the field get there early, intervene early and appropriately. That makes a huge difference in survival. And it can happen in a lot of places. We classically think of somebody collapsing with sports, running down the field. It's usually the choir boy everybody loves, straight A student running down the field, collapses and dies. I don't know why that is, but it can happen with sports or just at random and just at home. But either way, it's heartbreaking. But the key to this is early intervention. So the WHO defines sudden cardiac arrest as sudden unexpected collapse within 1 hour of symptom onset that was witnessed, or a subject that was observed to be live and well within 24 hours of the event. And something I really want you to take home, one of my favorite movies and one of the most quotable, but there is a big difference between mostly dead and all dead. And when you get to the scene, even if you've got no pulse, think of them as mostly dead, but something we can do to bring them back, because it happens. If you look at all the causes of sudden cardiac arrest in athletes, and this is in athletes alone, you can see there are some things really take up the bulk of it. Hypertrophic cardiomyopathy is a huge player, and we'll talk about that. Commotio cordis is a huge player, especially in sports involving objects. Coronary anomalies are surprisingly common, and we're not talking about coronary artery disease, a clogged artery thing that adults get from not taking care of themselves, but actually structurally abnormal coronaries. And then it gets smaller and smaller from there, but all these causes can be a cause of sudden cardiac arrest in somebody who's never done sports, sitting on their couch at home. So there can be many structural and functional causes of sudden cardiac arrest. Rather than read you the list, we'll kind of go through this in a little bit more detail. You can get primarily electrical problems, such as long QT syndromes, and there are a number of names of those, Romano-Ward, Gervais-Nielsen. You can actually get acquired long QT syndrome, and Brugada is getting to be recognized more and more common than we thought it was. WPW is one of the classic causes of sudden cardiac arrest in kids. You can get primary or idiopathic VT, and as well as exercise-induced VT, where somebody's perfectly fine at rest, but then the exerciser can go into VTAC. And we've actually seen those in front of us. A heart block can be another issue. And again, we'll talk about these in more detail. Commotio cordis is where you take an impact to the chest at just the wrong time and puts you into VT or VF. Drugs of abuse are common. You really have to think about that with when a kid goes down, and it goes down hard. The stimulants can do it, coke can do it, meth can certainly do it. Inhalants, do not underestimate the significance of that. Inhalants, including gasoline and glue and all that other stuff. Those things can be significantly arrhythmogenic and kill a child. If you have pulmonary hypertension, that's a huge risk of sudden cardiac arrest. And those kids would be known to cardiology, and the parents or whoever is around them should be able to tell you that. Atherosclerotic coronary artery disease, really uncommon unless you have a significant lipidemia. Teenagers won't be affected by this, but again, since we're such a weird specialty, we do see it. Okay, so let's go in more detail. Hypertrophic cardiomyopathy. The classic thing is where the heart is significantly thickened. Some people have called it an athletic heart or a big heart, that kind of thing. It is not that at all. Hypertrophic cardiomyopathy is where the heart is typically thickened, might not be, but it's associated with significant risks of sudden cardiac death. Here's the classic one. This is the same view in both these pictures, where the ventricular septum, which should be nice and thin, about 7 to 8 millimeters, has this huge bulge in it, and that obstructs blood getting out the aorta. And that's your classic hypertrophic obstructive cardiomyopathy. If you look at this, and the scary part, think about driving through a typical small town in South Dakota, the incidence of this is about 1 in 500. And that is pretty common. And actually, since it tends to run in families, you can imagine there could be a cluster of these things in a small town where families might not go far from town after they grow up. It's really, there's 12 main genes with a whole bunch of different mutations that we're still sorting out. So it can be kind of a mess, but again, so common. And what we're looking at is mainly structural proteins that are involved in the heart. When these get to be abnormal, the heart muscle itself is remarkably abnormal. When you look at it under a microscope, it is just a tangled mess and a significant risk of arrhythmia. This is actually a really classic, in fact, this is one I use for the residents and fellows, and of classic of left ventricular hypertrophy with strain. So when we look at this, we see huge forces here in the inferior leads, deep Q tall Rs, and the T waves are inverted in those leads. And in the precordial leads, you get inverted T waves all the way throughout the precordium. Again, with really tall forces, especially in the lateral precordial leads. This is left ventricular hypertrophy with strain. And if you get a kid that's passed out, went down hard, you get a monitor on him, and you see, doing this a while, you realize which way the T wave should be going. If those T waves are going the wrong way in a kid, you've really got to worry. This is what's going on. And this is a kid that is, even if you got him back, is a significant risk of going back into an ugly rhythm. So he needs to get into the ER quick. Here's an echocardiogram. And again, that big thickened septum. So what we're looking at is, here's the left ventricle and the right ventricle. And so the ventricular septum between them should be thin, but again, it's really thick. And here's the same heart, looking in cross section. This is the left ventricle here on the bottom. Big, thick, fat septum. So hypertrophied heart is, again, the classic type. Uh-oh. Whatever I did was wrong. Okay, we're back. So again, this is a autopsy specimen of somebody who didn't make it. This is left ventricle. Sometimes it can be so thickened that you actually lose the volume of the left ventricle. So try getting some blood flow with that. It can happen at exercise, even including when they stop exercising. Sometimes we'll see where everything's going fine, and during exercise, also they develop VTAC, little runs of VTAC like that. We take that very seriously. If anybody has unexplained syncope, again, the vasomotor syncope, you can explain. But if things don't make sense, you really got to worry that this person has hypertrophic cardiomyopathy. This is a picture down the bottom here of a family. I think he built that bike himself. Pretty good skills. But anyway, he had a family of kids, and one of his kids died suddenly. And they found out on autopsy that he had hypertrophic cardiomyopathy. They didn't know it. And they evaluated the other kids, and 2 of them actually had hypertrophic cardiomyopathy as well. After a long discussion, they ended up putting defibrillators into them. And those kids, even though their hearts looked structurally normal, both had their defibrillators go off and save their lives. So family history is a huge part of this. Okay, next topic, coronary anomalies. So here's a classic normal coronary. Here's a pulmonary valve in front and the aortic valve behind. And you have the left coronary artery coming off the left posterior facing sinus and branching to the circ and the LAD like it's supposed to. And the right coronary artery comes off the rightward posterior cusp and goes where it's supposed to go. But you can have all kinds of squirrely variants. You can have both coronaries coming off the right cusp, so it's taking this long circuitous route. One of the worst is where the left coronary artery comes from the same cusp and then goes between the aorta and the pulmonary artery. You can imagine what happens with exercise when these vessels get distended with blood. You can actually pinch this off and have a heart attack and die suddenly. Sometimes you get coronary arteries that run through the myocardium, and so when the heart's beating hard, it actually squeezes the left main coronary artery and you die. And you can get just a whole bunch of squirrely variants. So if somebody ever passes out and families around and say any heart problems, yeah, this coronary artery is goofy, get them in. This kid, even if he did survive, is at significant risk of another quick second event that could kill him. So take those kind of things very seriously, but they're out there. It's actually a pretty common cause of sudden death in adolescents and young adults. Unfortunately, most of the patients are usually asymptomatic until they arrest. Once in a while, you get somebody who complains of angina. Again, not classic chest wall pain or not classic vasomotor syncope, but they just get this recurrent atypical kind of chest pain, atypical syncope, and the pattern is really worrisome, especially if it happens with exercise. And those kids need to be seen. Even if they didn't pass completely out, even if they seem to be getting better, get them in, get them checked out. All right, another issue we're recognizing this a lot more. I don't know if it's any more common, but we're recognizing it a lot more. Something called arrhythmogenic right ventricular cardiomyopathy. And that's where the heart muscle, especially of the right ventricle, is really abnormal. It tends to be infiltrated with fat and connective tissue. And this is not a happy right ventricle. It is really at risk of arrhythmias. And these kids can just die suddenly for no reason at all, but especially with exercise. This is actually an EKG from a kid with arrhythmogenic right ventricular cardiomyopathy. And as you can see, he's having a really nice run of VTAC here. These kids need really high-tech, high-risk intervention to save their lives. And a scary thing is that with arrhythmogenic right ventricular cardiomyopathy, the more you exercise, the more your risk is. The kids that have been active in sports from the get-go are actually more at risk of sudden cardiac arrest than the kids who are couch potatoes their whole lives. So we still recommend everybody get on exercise unless told otherwise, but that's a concern. And again, so with these kids that we know have ARVC, we definitely prohibit them from exercise. And a kid who decides, I'm going to do it anyway, and arrest, that's a huge, huge issue. All right, next problem. Long QT syndrome. And there's several families of this, but what it amounts to, so we can look, probably easier to see it on the bottom. So here's a P wave, here's your QRS, and this is the T wave, way over toward the next P wave. This is where the QT interval is abnormally long, and there are a number of reasons for that. But the main concern is that what can happen, and it just happened to catch on this EKG where everything's going along fine, then they get usually an ectopic beat, and they get an R on T phenomenon, and they go right into VTAC, often torsades. And they can collapse and die from this, certainly. There are three main types of long QT syndrome, and the risks are really determined what type you have. There's one in which if someone is swimming, there are increased risk of going into VTAC. And it certainly, actually in all the types of long QT, but especially with long QT1, we do not allow the kids to swim. Warm or cold water. What happens is, especially if you go into cold water, you get a diving reflex that by putting cold water on your face, and that slows the heart rate down. And then they get that extra beat, that R on the T, and just float up dead. Long QT2. So anyway, with long QT1, somebody who has a syncope in the water, passed out in the water, you've really got to think about that, and they need to get into the ER now. Long QT2 is where somebody may be sleeping or even just sitting there calm and something startles them and their heart rate suddenly jumps up to get the R on T and die. This is the one where we've found the people who the phone rang in the middle of the night and they never even made it to the phone. just that sudden awakening is enough to put them into VTAC. Long QT3 is one where they just die in their sleep. Again, seriously scary. You might not know this in a particular patient, but family history of any of this kind of thing, death with swimming, death with a start, death at sleep, you really need to take seriously anybody that passes out. Another ugly thing to consider, this catecholamine-sensitive polymorphic VTAC, or CPVT we call it because we're lazy and we like abbreviations. This is actually from a treadmill test where everything's going along fine over here on the left side of the screen. PQRST, everything's fine, and goes right into VTAC. It's got a nice spindle shape to it, doesn't it? And so it's catecholamine-sensitive, which means when you exercise, they can just go into these ugly arrhythmias. We heavily medicate these kids. We do ICDs. We do what we need to keep them alive. And this can happen not only in kids, but adults. So just for fun. Next topic, Wolff Parkinson White. Again, this is sort of the classic running down the field, passes out and dies kind of thing. And what we're looking at is everybody's got their own pacemaker and their SA node, and the electricity should be going down the pathway to the His-Purkinje and then fire the ventricles. But unfortunately in WPW, the electricity goes back up through this accessory pathway and sets up its own circuit. And that actually has a unique look on CKG because in normal sinus rhythm, the electricity actually goes downward in it. And so you get a really short PR interval. And because of that, you get a really wide QRS. That's classic Wolff Parkinson White. And these folks are at risk for not only SVT, but also VTAC. So here's the classic EKG of that, where again, short PR, wide QRS. And if you see that even on the ambulance monitor, you know, that PR is really short and the QRS is broad. And the kid who passed out or is having palpitations, get them in. What you might hear about is a delta wave. That's because of that abnormal pathway stimulating the heart early, forms kind of a triangle in different leads. So again, that upsloping, we call it a delta wave. So here, this is actually one of those kids, different kids, 17-year-old with palpitations. And this is a nice case of SVT, nice and fast, narrow complex. And anybody who passes out with SVT definitely needs to get in the ER and get seen. We can get SVT being more of an annoyance than anything else, but certainly it can be fast enough, worrisome enough to cause sudden death, okay? This is a 2-day-old with respiratory distress. He actually had the risk of SVT, so he ran SVT. Look at this rate. This rate is almost 300 beats per minute. And this is a kid who is going to die unless you deal with this. So in this case, we gave adenosine, which blocked it out and went back into sinus rhythm. Another concern, ruptured aortic aneurysms, which can come from a number of different things, especially Marfan's, but Ehlers-Danlos, a bunch of other different inflammatory conditions. Somebody's ever had a coarctation or bicuspid aortic valve. Actually, a really good rule: anybody passes out or has any chest pain or anything worrisome, and they have chest scars from surgery, get them in. They're probably in one of those high-risk groups. Even Turner syndrome, Noonan syndrome, those kind of things. Just ask some basic medical history questions, and if anything pops out, get them in. And what we're looking at is dilation of the aorta, and the bigger these aneurysms get, the more likely they are to rupture. Here's the classic Marfan's look to it, and this little guy, with a really skinny guy, long skinny arms, long skinny fingers, and they tend to be very tall. These dissections can take a number of forms depending on where it decides to dissect. Either way, they're all seriously dangerous, and these folks need to be seen in a high-level trauma center without delay. Classic pain from ruptured aortic aneurysms is crushing chest pain. Actually, the people that survive it said it felt like somebody was ripping my back in half. Sometimes it's pulsatile, but again, coarctation, bicuspid aortic valve, Marfan's, those things are a worry. Even in the field, without a stethoscope, if somebody has unequal pulses, arm to arm or arm to leg, and if you have a blood pressure cuff, just take blood pressures in both arms. If it's unequal in the arms, probably more than 5 millimeters of mercury difference, you've got to think that they're dissecting. On an EKG, you can certainly get ST changes because you can dissect all the way down to your coronaries and end up with an acute MI. Commotio cordis is a big deal. Actually, as you remember from the earlier slide, it could be a big player in athletes. It's due to low energy trauma to the chest wall. What happens is you get the impact on just the wrong spot on the T wave, and the kids can die. It can happen with baseball, softball with those projectiles, certainly ice hockey, lacrosse, or even there was a study done I was looking up recently out of China, hands, elbows, knees to the chest can cause commotio cordis. And this is one I just found recently. This guy is a landscaper. He was out landscaping, just trying to work, and somebody else was mowing that lawn, and the lawnmower picked up a lacrosse ball, and that's where it hit him in the chest, and it dropped him right away. They resuscitated him, shocked him out of it, got him to a tertiary trauma center, and actually he survived and did well. But guy was just gardening, so always ask about whatever mechanism you can find with this. Certainly the risk is higher, as you can see in baseball, and especially when they get more aggressive in the sports in the teen years, a lot more likely to be a victim of commotio cordis. You really have to think about toxicities for ingestions and all. This kid took a whole bunch of Tessalon pearls and decided to go into an accelerated ventricular rhythm. This is actually after resuscitation. He was a tough kid, but we were able to get him through. Another issue, pericarditis, typically associated with a viral syndrome of anything. And it could be COVID, could be whatever. But you end up with inflammation and fluid accumulation around the heart. And what can happen is that you can build up so much fluid that it actually impedes upon the heart and squeezes the heart, and your cardiac output falls so low. It can be inflammatory, can be traumatic, or even after cardiac surgery, you can get it. The presentation is they get really short of breath. These are ill-appearing people. The orthopnea, the chest pain, especially when they lay back the mirror, have that friction rub, muffled heart sounds and all that. Diffuse ST changes, really decreased voltages. If you grab a film in the ER, you'll see a cardiomegaly. An echo, I think it pictures better, so I'll show you that. But here's the good example of the ST changes. We give kids 1 or 2 millimeters of ST change and consider that normal, but this is way more than that of ST elevation diffusely in all the leads. So this is an example of somebody, one of our kids, with an effusion. So here's the heart beating in there like it's supposed to, but all this black is fluid. The heart is being squished and just really not happy. So I stuck a needle in his chest and drained the fluid off. Now the heart's a whole lot happier. And this is something that you accumulate over just a few hours. Very worrisome, especially the quicker it accumulates, the more worrisome it is. Oh yeah, another thing. These things can happen anywhere. This is a kid who just had a viral syndrome, was in our ICU, and decided to go Brady. So you see the heart rate really slowing down, alarms are going off, and our astute nurses jump over there and start chest compressions. And do enough chest compressions, they start seeing the QRSs come back, and we got a heart back. It can happen that quickly in the hospital or even at home, just to give you more angst. It's the kind of stuff I think about. Arrests happen. All right, I show this because it's my favorite onesie. I love this one. All right, last topic. Your neighbors have problems. There are about 32,000 kids born per year with congenital heart disease, and a lot of it's critical, some of it, most of it not. But you've got a whole bunch of children in the school systems with repaired, we call it, congenital heart disease. And long story short, we've got about 2.3 million adults in this country with congenital heart disease. And that was several years ago. Some of them severe. Especially if you get a young person who has a pacemaker, you could, as you're doing your exam, find a pacemaker, you gotta think congenital heart disease. And there could be something awful going on. We've got kids walking around with dilated cardiomyopathies from a number of different issues. But any child with a history of dilated cardiomyopathy or any kind of cardiomyopathy who's doing anything worrisome, just get them in, package them up, get them into the ER. So we do have this expanded population of adolescents and adults, and they have all kinds of problems: rhythm problems, pulmonary hypertension, residual shunts, some are at risk for strokes, ventricular dysfunction, valve dysfunction, even endocarditis at random. So just a nice worrisome population. Actually, if you look at the ones that sudden cardiac death-free survival after congenital heart disease surgeries, tetralogies, coarcs do reasonably well, but some of the things like transposition and aortic stenosis are at significant risk of dying very early. You can see the survival-free population here and just the number of years they live. It can be really worrisome. And you look at sudden death in these folks, again, significant risk, especially TET, coarctation, aortic stenosis, transposition, especially in their second decade of life. Coarctation is where you get a narrowing of the aorta, and there are a number of ways of fixing that. But when you look at these survival after coarctation repair, the mean age of death is 38. It's substantially worse than the rest of the population. Somebody I trained with had a coarctation repair, and he was actually 39 when he was driving along, and he dissected his aorta, crashed his car. Fortunately, people were paying attention. They were able to make him a survivor, and he's back to work now. Tetralogy, basically, it's where you get obstruction of the pulmonary valve and a VSD, and you can fix that by opening all that up and patching the VSD. Trouble is, they're at significant risk for early death, mainly from arrhythmias. So again, anybody with a chest scar, median sternotomy scar, or a thoracotomy scar, take that very seriously. Transposition is another one. And that's where you should have long serious circulation. In transposition, all the blue blood comes back to the heart, but goes out the aorta because the aorta is in the wrong place. And that goes back to the body. So you got blue blood circulating around the body, but then the nice oxygenated blood comes to the left heart and goes back out to the lungs. It's a heart designed by the government, I think. So they used to do what's called an atrial switch, where they would basically rearrange the anatomy so you get the blue blood going out to the lungs, red blood to the body, which is great initially, but they have a lot of problems, especially with rhythm and heart failure. And they get all kinds of different obstructions. For them, their survival, if this graph shows if you don't do anything with transposition, they just all die really early, pretty much all of them within the first year. But the mustard procedures, which is what it's called, they tend to do well until about 4 or so, then they really start tapering off. So we don't do those anymore, but it was the best they could do at the time. Mainly because you lose rhythm. The number of kids at 21 years of age that have had a mustard procedure for that are in sinus rhythm, it's about a quarter. It's pretty miserable. So the vast majority of them get pacers and ICDs and all that. And this is an example of one of our kids from his Holter, and he's just in a really slow junctional rhythm at 35. Now we do an arterial switch where you actually do switch the arteries. It's a very complicated thing to do, but cardiology is getting a whole lot better at it. Trouble is you got to switch the coronaries, and so that can cause some significant issues, especially in the little ones, or even teens trying to do sports that aren't staying in follow-up can be a significant risk of sudden death. And the last one is a single ventricle population, and this is a huge mix, but what it amounts to is one half of the heart is not good enough to support circulation, and they go through a series of complicated surgeries just to save their life at birth and then up through adulthood. And these folks are at significant risk of rhythm problems, heart failure, a bunch of other things, including sudden cardiac arrest. So in summary, it's about prevention, which is where the kids should be staying in with the primary docs and getting seen. If they are having any symptoms, get them checked out by a cardiologist. Certainly the screening, EKGs, if somebody's doing something worrisome, get an EKG, get them checked out, and just preparing for it. In the interest of time, I would encourage you to check out this YouTube video. If nothing else, look up, Google Project Atom, which is about saving children with sudden cardiac arrest. And the key is, with all these arrests, is having a plan, having not only defibrillators, but having a plan about where it is, who's going to get it, who's going to call, all these things. And if all those pieces are in place, the survival in the pediatric population goes up dramatically. So it's a matter of preparation and having the people around like you who can intervene early to save their lives. At this point, I'll open up for any questions if anybody has.
Hi, Dr. Waltz. This is Margaret.
Yes.
And I do have a couple of questions that folks have asked. The first one I have, is there a benefit to using mean arterial pressure to gauge end organ perfusion post-ROSC? And if there is, what would be a good target number?
The first answer is yes, it's a good thing to measure, but the target number varies so much by age. If you're looking at a teenager, for them to have a reasonable mean pressure of 80 to 90 would be good. But if somebody's a 5-year-old, that would be hypertensive. It does vary a lot by age. I think it's a matter of getting comfortable with the different blood pressures in the different age groups.
Okay. Is there a way that you could, and we can put it in the guidebook later, but bring back up that last slide you had with that web address on it?
Absolutely.
And then that way the folks can write it down. Or they can take a picture. Taking your cell phone and taking
everybody's got a phone now.
Yep, they do, and it's a great way for them to do that. Okay.
Yeah, actually, good luck watching this the first time and not tearing up.
That's a nice warning. Another question I have is, if I am a BLS service and they only have adult patches on their cardiac monitors, is that putting the child at risk for long-term problems after resuscitation using adult voltage versus pediatric?
The short answer is yes, but even in our PALS protocols, which we're really into pediatric advanced life support, we really hope people have the PEDS pads for AEDs and whatever else. But if you don't, you don't say, well, we don't have the right pads, so the kid dies. You do the best you can and put the pads on the kid and shock them. Kids are remarkably tough, and there might be a burn. Long-term injury, probably not, but long-term injury is better than death. And so you work with what you got. It is good to pester the administrators to say, you know what, we need the right products to take care of kids.
Wonderful. Thank you. Another question we've received, with an aortic dissection, which arm would have a higher BP? Would you be able to tell?
Most of the time, the right arm has the higher blood pressure because the dissection is distal to that takeoff. But that's probably the best rule. If the right arm is higher than the left arm, you can get some other weird dissections, but usually in a dissection, the right arm is higher than the left arm because that aneurysm, that dissection, is obstructing the left subclavian.
Okay, excellent. The folks really enjoyed the lecture because they're asking some more questions.
Okay,
so good. The next one we have, have you been seeing any cardiac problems in peds due to COVID-19?
Yes, but it's incredibly rare. Not to get too political, but I'm ready to be done with COVID. Actually, I've been ready to be done since March, probably like everybody else. The media and the politicians have been having a field day, and even the CDC and WHO have said a lot of, I'll be nice, not necessarily valid things. But I was actually looking on CDC's website last week, and according to the website, in this country, under 18, 100 kids have died from this. It's not a significant risk for kids. Yes, we've seen it, but we've seen a bunch of everything else. There's a real lack of perspective on how much of a risk COVID is to kids. So it's a yeah, again, trying to not get too political. If somebody's sick, stay home, wash your hands, don't spit on old people, good rules of life. But the kids are at so much less risk than older people. Even, I feel old enough. I'm not worried about it. There's so many things out there. There's all the influenzas, all the other coronaviruses, so many different things can happen. We just need to not be afraid of living our lives. Actually, good case in point. I've got a kid who's just got a train wreck heart. He's had three surgeries already, no, 4, and he's 18 months old. And both of his parents came up with COVID, and he blew through it without a symptom. And we're seeing that a lot in the pediatric population. The younger you are, the better.
Excellent. Okay, and the last question that we have is, have you seen any genetic links with WPW?
Sort of. We see familial links that we have not yet tracked down which gene or genes are directly involved in WPW, but it can definitely run in families. Actually, the EKG I showed you was of my son, who just by a bizarre sort of circumstances, I brought him in to be a crash test dummy so I could try out a treadmill we were thinking about buying, and hooked him up, and he had WPW, and
wow.
And we put him through an evaluation because you just do what you can, and he was actually at high risk for sudden cardiac death. And the week prior, we had been out in the Black Hills with the Boy Scouts doing heavy long range backpacking. So yeah, some people's kids. So it was a no-brainer for me. I set him up with somebody I trust, and electrophysiologist, and he had an ablation. Now he's fine.
Excellent. Well, that ends our time with you, Dr. Waltz. We greatly appreciate you taking the time to speak with us on this whole range, because, yeah, we deal with a lot of adults, but we don't deal with that many pediatric patients. So you've covered a lot of ground for us, and it's been great information. For those of you who do have questions later on, we can get the contact information. It should be in your guidebook on how to get a hold of Dr. Waltz if you do have other questions. But otherwise, thank you so much. And for those of you attending the session, our next session will be beginning at 15 after the hour. That's in about 7 more minutes. So you're going to have to log out of this Zoom session and log into the next one. Don't forget to do your survey, and we will be talking to you guys in a little bit. Thank you so much for joining us. See you in a moment.